Okay, why don't we go ahead and get started? Hello, everyone, and welcome. My name is Dr. Heather White. I'm the Executive Director for Together for Health, and I'm pleased to welcome you to the next installment in our ongoing webinar series, which highlights important topic areas in global cervical cancer prevention and control. In recognition of Global Immunization Week, excuse me, we are excited to welcome our colleagues from the single-dose HPV vaccine evaluation consortium to present the latest evidence and resources on the single-dose HPV vaccine. This consortium is made up of research scientists who are tasked with collating, evaluating, and disseminating the latest evidence regarding single-dose vaccine to inform global policy discussions and program guidance for the HPV and cervical cancer communities. Following the presentations, we will open up the discussion for question and comments, so I encourage you to share your questions with this group. Before we begin, a few reminders regarding logistics. All attendees are on mute. We will have, excuse me, roughly 15 minutes of Q&A, and I'll moderate that session. If you have a question or comment for the presenters, please do write your question in the Q&A box, and we will do our best to get to all of them. If not, we'll try to follow up directly following the webinar. The webinar is being recorded and will be available on our website after the event. If you'd like to see the catalog of all of our webinars, please visit our website at www.togetherforhealth.org. And we'd love your feedback on today's topic or any suggestions for future topics for this webinar series. At the end of the presentation, we'll post links on how you can get on our mailing list and contact us directly. Okay, and with that, why don't we get started? I have the pleasure of introducing our three speakers today who will be presenting in order of their presentations. First, we will hear from Dr. Gina Ogilvie, who is a Tier 1 Canada Research Chair in Global Control of HPV-related diseases and prevention, and professor at the University of British Columbia in the School of Population and Public Health. Dr. Ogilvie is a senior public health scientist at BC Centre for Disease Control and senior research advisor at the BC Women's Hospital and Health Centre. Her research is focused on both the public health and clinical aspects of reproductive health, sexually transmitted infections, excuse me, HPV screening, and the HPV vaccine, and her findings have been highly influential in setting and directing health policy, both in Canada and globally. Next in the presentation, we'll hear from Dr. Anne Schwind, who will present on the data from clinical trials and observational studies. Dr. Schwind is trained in pediatric infectious diseases and is a specialist in vaccinology. With over 20 years of experience in clinical research and development with GSK vaccines, she made important contributions to the development of several vaccines, including rotavirus, DTaP-IPV, HPV, influenza, and zoster vaccines. Dr. Schwind joined the Center for Vaccine Innovation and Access at PATH in July of 2020 as the initiative team leader for HPV vaccines. And last, we'll hear from Dr. Jane Kim, who will present on the latest modeling data on the single-dose series. Dr. Kim is the Dean for Academic Affairs at the Harvard T.H. Chan School of Public Health and K.T. Lee Professor of Health Economics in the Department of Health Policy and Management and the Center for Health Decision Science. Dr. Kim's research focuses on the development and application of mathematical modeling methods to evaluate health policy issues with a strong interest in women's health. She's led on the evaluation of the cost effectiveness of prevention strategies against cervical cancer and other HPV-related diseases for informing decision-making globally and working closely with U.S. National Cancer Institute, the U.S. Preventive Services Task Force, the Bill and Melinda Gates Foundation, and most recently, the WHO on cervical cancer elimination. Okay, and that is all of our speakers today. I want to thank you all for being here and for presenting on this timely and important topic. And with that, I'll turn it over to you, Dr. Ogilvie. Thank you.
Thank you so much, and thank you for the very warm welcome. And I'm delighted on behalf of the team to be here and to share some of the exciting endeavors we're involved in. Next slide, please. So if you've been spending some time in the cervical cancer space, some of the information on this slide won't be news to you, but just to make sure we're all sort of understanding the foundation, we want to make sure you have the context of what we're working in. So as many of you know, cervical cancer remains a leading cause of death, cancer death particularly, among women in low and middle income settings. And more than 600,000 cases and more than 340,000 deaths occur annually, with more than 90% of those deaths occurring in low and middle income settings. And, and what I'd like to underscore is that with the tools we have in terms of vaccination and screening, the majority of those deaths could be prevented. And the reason they could be prevented is because we have a vaccine that works very, very well. And we also have screening tools that allow us to detect cancer and precancer very early and treat it. And this is all possible because we now know that HPV is present in virtually all cervical cancers and is a necessary cause of cervical cancer, meaning it needs to be there for cervical cancer to develop. So given the development and advancements, both from the vaccination side and also the screening side, in November 2020, the WHO actually named cervical cancer as a leading public health problem. And then they launched their global strategy to accelerate the elimination of cervical cancer as a public health problem with the following 2030 targets. So the targets include getting girls fully vaccinated with HPV vaccine by age 15. So getting 90% of girls fully vaccinated. We were aiming for 70% of women to be screened with a high performance test by 35 years of age, and again at 45 years of age. And then ensuring that the majority, over 90% of women who are identified with cervical disease, receive treatment. And that includes both 90% with the precancerous lesions identified by the high performance test, and also 90% for women with invasive cancer having that appropriately managed. So these are the WHO targets that we're all aiming for, and they're sort of our North Star as we think about programming for cervical cancer elimination. Next slide, please. So let's dig a bit into HPV vaccines. So current HPV vaccines that are on the market are what we call prophylactic or preventative. So they need to be administered prior to exposure with HPV. So before you acquire HPV. And so optimally that's usually before sexual debut. So in the vast majority of countries, that's at quite a young age. So these vaccines were introduced in 2006, and they were introduced on a 3-dose schedule. That's what the clinical trials had been done on, and so that's how they were introduced. However, after some years of doing research, we were able to move from a 3 to 2-dose schedule following expert evidence review based on the data that was out there that showed that actually 2 doses was what we said was non-inferior to 3 doses. So it gave you the same protection, same coverage. So we could move from 3 doses to 2 doses. There's now exciting and accumulating evidence that a single dose of HPV may elicit a sufficient immune response that can also protect against HPV infection. Next slide, please. So currently, as I mentioned earlier, the WHO recommends 2 doses of the HPV vaccine for girls 19 to 14 years of age, with some dosing flexibility for the second dose that can start as early as 5 months after dose 1. But the WHO remains and continues to recommend 3 doses for girls over 15 years of age and immune compromised girls, so including HIV infected, which is the original dosing recommendation from 2006. And during the current supply constraints, so during our current challenges with actually enough HPV vaccine to meet the needs that everyone wants, SAGE has recommended that countries who have introduced the HPV vaccine pause the vaccinations in girls, pause vaccinations in older girls, and pause in multi-age cohorts to really make sure that every vaccine you're giving is going to have the most optimal benefit for preventing cervical cancer, which is our objective. And also to adopt an extended interval of 3 to 5 years between those two doses that are recommended. Next slide, please. So currently, here is a summary of the available HPV vaccines. So we've got Cervarix, which covers off types 16 and 18, Gardasil, which covers off 4 types, 6 and 11, which are associated with genital warts, and 16 and 18. These 16 and 18 are the most sort of highly oncogenic subtypes. With Gardasil 9, which has 9 subtypes, and you can see there the additional subtypes that were added to Gardasil. We also have Sequelin, which is limited to use in China, and that has 16 and 18. And you can see here the proposed or the accepted schedules right now for 2 doses and for 3 doses in this slide. Next slide, please. So it takes a moment to orient yourself to this slide, but I think it's actually tells a really, really critical message. So what it tells you is where there's been where there's been both looking at the introduction of the HPV vaccine, but also what is the burden of disease in the country. So it tries to tell a story of where you've had high rates, high burdens of disease, and low rates of introduction, or moderate level of disease, moderate levels of introduction, etc. So what I really want to draw your eye to is this very dark burgundy color, because what that is are the groups that have highest mortality rates, so highest burden of disease, but also are having trouble with introduction. So you can see some have a national introduction with a dark burgundy, and then you also see countries that have no introduction. And so you can see that light pink, and then you can see that lighter orange are countries where they have significant burdens of disease, but have not been able to, at this point, have national introduction of vaccine programs. Then you can see a lot of that is concentrated in sub-Saharan Africa, and so and low and middle income settings. And that's what we talked about at the beginning, that a lot of the disease is shouldered in those settings, but we're also still looking to get introduction of vaccine programs. And so that's part of what is drawing us and really focusing us on single dose in order to hopefully optimize and accelerate introduction of HPV vaccine programs in those settings. Next slide, please. So what we want to do as part of the consortium is really provide the data to expand the access to the HPV vaccine. And we strongly believe that if we can demonstrate that a single dose of HPV vaccine is effective, we could accelerate the introduction in those countries that I just highlighted for you that have yet to introduce a vaccine, but also facilitate in those countries those countries that I showed you that have a high burden of disease and have introduced a national program. We could offer ways to simplify and actually make those programs more efficient with a one-dose strategy. And we could also, with a one-dose strategy, reduce the potential for supply shortages and delivery challenges, such as we've seen this last year with the COVID-19 pandemic. Next slide, please. And I'll just talk very briefly about the impact of the supply shortage and the COVID pandemic. So we've seen with the supply shortages around the world, some countries have chosen to only vaccinate one age cohort instead of the multi-age cohort of 9 to 14 at introduction following routine immunization. And the COVID-19 pandemic has had lessons for us all across the world in terms of a vast number of things. And as it relates to HPV vaccine, what we've seen is countries have had to delay introducing the vaccine. And also countries have had to move from the very efficient adolescent program of school-based programs to facility-based programs. And also in other jurisdictions, we saw that the second doses were delayed for months. And we're concerned that girls are now aging out of the eligible cohort. Next slide, please. So you saw the introduction of this team. So this consortium encompasses 8 leading health and research institutions, and we're working together to collate and synthesize the existing evidence to actually evaluate and also evaluate the new data for the potential for single-dose HPV vaccine. And here are the team members here. Next slide, please. So right now we have an evidence review that's available that summarizes the existing evidence from trials, from non-trials, so lots of cohorts and observational studies, and the impact and economic work into one paper. And the third edition is now available, and we're working on the fourth that'll be available in 2022. And we have a synthesis that's available in English, French, and Spanish. So I'm now going to hand it over to Anne to talk a little bit about some of the evidence from the clinical trials and observational studies that we're excited to share with you. Thanks.
Thank you very much, Gina. Good morning, good afternoon, or good evening. So my name is Anne Schwind, and in the next 10 minutes or so, I will try to summarize the evidence from HPV single-dose vaccination coming from clinical trials. Let's next slide, please. But let's first look at some of the rationale for single-dose HPV vaccination strategy. So as Gina mentioned, the current HPV vaccines that are still given on multi-dose regimens are highly efficacious in preventing persistent infection, and persistent infection are a necessary prerequisite for the development of cervical cancer. The HPV vaccine has already also been shown to be highly efficacious in the prevention of cervical lesion associated with the vaccine genotypes. And just a reminder that HPV 16 and 18, which are included in all the vaccines that are licensed as of today, actually are responsible for 70% to 80% of cervical cancer worldwide. So the vaccines elicit a strong and durable neutralizing antibody response. And neutralizing antibodies are known to be the main mechanism for vaccine-induced protection and need to be present prior to exposure to HPV. So the antibody response that is elicited by the vaccine is stable, with data up to more than 10 years post-vaccination. And the seroconversion rate in young women is nearly 100%. What was observed is that after a single dose of HPV vaccine, the durability of the antibody response remains. And even so the quantity of neutralizing antibody is somewhat lower. The quality is similar to multi-dose vaccination. So what is the evidence from on single dose from clinical trials? Next slide, please. So what the consortium does is to look at the publications that are out there, and through a systematic review that was conducted on the publication reporting on efficacy and immunogenicity of single-dose HPV vaccine compared to multi-dose schedule. 7 articles were identified that were reporting on 4 studies. Except for one study, which was a small study in the US in 10 subjects, the data originated from randomized controlled trials in which some of the participants failed to comply with the full dosing regimen of 2 or 3 doses. The literature search did not identify any randomized controlled trial that really directly compare a single dose to 2 or 3 doses. However, data from 2 large vaccine efficacy trials with long-term follow-up for many years of the subjects are the basis for the concept of single-dose vaccination. And those trials are the Costa Rica vaccine trial, and I will present some of the data from that trial in the next slides, as well as the India IAC trial that I will also mention later on. So what are the main findings from those publications? So first is that HPV 16 and 18 infection are very low in subjects having received any doses of HPV vaccine, and significantly lower than what is seen in women that are unvaccinated. Further, the vaccine efficacy against HPV 16 in 18 is comparable between 1 dose, 2 or 3 dose schedule in young women up to 11 years post-vaccination. And then in terms of immunogenicity, the proportion of participants that seroconvert to HPV 16 and 18 in any vaccine regimen is very high. So in the next 2 slides, I will present you some data. Next slide. First, we will look at some data illustrating the vaccine efficacy in preventing HPV 16 and 18 infection. And these are data from a combined analysis of the Costa Rica vaccine trial, as well as the Patricia trial. Both are large phase 3 trials that assess the efficacy of the bivalent vaccine. So data are from a dose stratified analysis in women that were HPV negative at baseline. And I would like to draw your attention to the bottom part of the table that depicts the vaccine efficacy in the prevention of persistent HPV 16-18 infection. And the definition of persistence here is at least 6 months of the virus being found in the cervical specimen. So the vaccines shows to be highly efficacious in the prevention of persistent infection. And what you can also see that the vaccine efficacy estimates for 3 dose, 2 dose, or 1 dose, and this is in the red box, are very similar. Next slide. So in terms of immunogenicity, this graph shows the durability of the immune response against after bivalent vaccination, and these are also data from the Costa Rica vaccine trial. So on the x-axis, you will see the years post-vaccination, and here the data up to 11 years post-vaccination. And on the y-axis, you see the antibody level. They are depicted here for HPV 16, but the figure for HPV 18 is very similar. So what can we observe? First, after vaccination, 2 to 4 years post-vaccination, the antibody level reach a plateau that is really sustained up to 11 years post-vaccination. Secondly, we can see that after a single dose, and this is the blue line on that graph, the antibody level are somewhat lower, approximately 4 times lower than after a 3-dose regimen, which is the purple line. However, those antibody level after a single dose are substantially higher than what is seen, the antibody level that are seen after natural infection, which is the dark line at the bottom of the graph, and this approximately 10 times higher. So we can conclude that the vaccine is able to elicit stable antibody level that are maintained up to 11 years post-vaccination, this with different dosing regimen, and that the level of antibody remains at least tenfold above natural immunity. So we are going now to switch gears and to look at some of the data on single dose from observational studies. Next slide. First, in terms of immunogenicity, so the consortium performs literature search that look at articles and publication that look at observational studies reporting on immunogenicity of different dosing schedule. And again here, the data that were identified are mainly from participants having failed to complete their full vaccination schedule. So what are the observations? They are very similar to what has been seen in the clinical trials. So first, a single dose of HPV vaccination results in high rates of seroconversion and seropositivity that is maintained over time. And data from the observational studies went up to 8 years post-vaccination. Secondly, the antibody titers after one dose are somewhat lower than after 2 or 3 doses. However, the clinical relevance of this observation is unclear, since minimal antibody level sufficient for protection has not yet been identified for HPV vaccines. However, the titers in one dose, after one dose, remain stable over time and were considerably higher than with natural infection. And then there is one additional observation which is very important, is that some of the adolescents demonstrated higher antibody titers after a single dose than the antibody titers that were observed after a 3-dose regimen in adult women in a population where efficacy has been demonstrated. And this is important since you heard also from Gina that pre-adolescents are really the main target population for vaccination before sexual debut to have the maximum efficacy of the vaccines. Next slide. So in terms of vaccine effectiveness, and I would like first to really mention that the vaccine effectiveness of HPV vaccine has been clearly established with a decrease in cervical lesions following implementation of HPV vaccination program, and that has been demonstrated in several countries such as the US, Canada, Scotland, Sweden, Australia. So the consortium did a systematic review of the literature, but looked really at data on effectiveness by number of doses. And that yielded quite a substantial number of studies which look at different outcomes, such as HPV infection, but also clinical outcomes. So what were the main findings? Most of the studies found highest effectiveness with 3 doses, followed by 2 doses, and then 1 dose. However, since the data were in the setting of national 3-dose vaccination programs, they were subject to some biases. Women failing to complete the vaccination schedule might have had a higher risk of HPV infection, and that would then result in apparent lower effectiveness with fewer doses. Nevertheless, half of the studies found significant vaccine effectiveness for single-dose HPV vaccination, and there was a higher effectiveness estimates that was found in younger age at vaccination. And again, that's reflecting the fact that those women have received the vaccine prior to infection. The main point is that the more recent studies that really looked at vaccine recipient of younger age or with analysis that were stratified by age and vaccination found high effectiveness with 1 dose or similar effectiveness with 1, 2, or 3 doses. And again, this is important since the pre-adolescent, adolescent age group is really the target for primary prevention of cervical cancer through vaccination. So I'd like to illustrate the finding on single dose with data from a national cohort study from Australia. Next slide. So this was a retrospective cohort study using linked regional data registries that assessed protection against high-grade cervical lesions after vaccination with the quadrivalent HPV vaccine. So the data included more than 250,000 screened women. 20% of those women were not vaccinated. 70% had received 3 doses, and a substantial number, more than 8,600 women, had received a single dose. And vaccination occurred up to 7 years prior to screening. So what you see on the x-axis is the time after screening, and on the y-axis, what you see is translated in the probability to develop high-grade lesion. So what can we observe? First is the vaccine confers protection against high-grade lesion. You see in the pink line, these are the unvaccinated women, and they have a higher risk of developing a high-grade lesion compared to the purple lines, which are lower, that represent the vaccinated populations. And then what you can see, and it's very difficult actually to make up the lines that represent the women having received 1, 2, or 3 doses, because they are really almost superimposed. So that means that the vaccine effectiveness in preventing high-grade lesion is very similar after any of the dosing regimen. So one can conclude that 1 dose had comparable effectiveness as 2 or 3 doses in preventing high-grade disease in a high coverage setting in women that were vaccinated before the age of 15. And now I will turn it over to Jane for the presentation on modeling evidence for single dose.
Great. Thank you, Anne. I am pleased to be here to summarize some of the modeling work that has been conducted as part of this consortium. The goals of the modeling work group are to synthesize existing as well as generate new model-based evidence about the effectiveness, pardon me, and cost effectiveness of vaccination by number of doses. So it's taking the data that you just saw and integrating it into our models to project out what are some of the long-term health outcomes and economic outcomes. Next slide. The main modeling groups in this consortium comprise my group at Harvard, a group at the University of Laval led by Marc Brisson, who has developed a set of models known as HPV Advise, and a group at the London School of Hygiene and Tropical Medicine led by Mark Jitt, who has a modeling platform known as HPV Prime. These models are adapted to reflect important attributes of a particular setting and require a large number of data, including demographic data, sexual behavior, HPV prevalence, cancer incidence, and HPV type distribution from these settings. Our models have been extensively used in different countries around the globe to inform decision-making. And for most of our analyses in this consortium, we focused on low and lower middle income countries. Each of our models are able to project a range of both health and economic outcomes. So including kind of longer term projections of cancer cases and deaths averted, life years gained that may be adjusted for either quality or disability. And from these, we can calculate conventional measures of value or cost effectiveness. So in the traditional frame of cost per life year gained or cost per quality or gained or DALY averted. Next slide. This slide just shows an overarching framework from my group's model, which involves linkages across 3 different types of models. The first on the far left is an agent-based model that captures sexual behavior among individuals in a population, as well as HPV transmission. The middle model is a microsimulation model. So it's an individual-based model that represents the natural history progression of HPV infection to cervical disease and cancer. And it also simulates very detailed screening protocols. And the third model to the far right is one that scales up the effects of both vaccination, HPV vaccination, and screening from these preceding individual-based models to the population level for whatever country or setting that we might be projecting our estimates in. Next slide. So to give you an idea of some of our core questions and explorations, in this graph, I'll depict how HPV-16 prevalence in females, and in this case, we've restricted to age 12 to 59 years, is projected to change over time under different scenarios of HPV vaccination. This particular analysis, this graph that I'll show, was in the setting of a high-income country, but we have found that these trends are generalizable across settings. So I'll first show you outcomes under an assumption of no waning or lifelong vaccine protection. This first black line shows a scenario of no HPV vaccination, which stays stable in the population over time. The next, if you click on the next line, the green line shows how the prevalence of HPV-16 drops in this setting when we implement a program. Here we're assuming 2-dose vaccination, and that the efficacy of the vaccine is 100% over the lifetime. The coverage in the population of 12-year-old girls here is assumed to be 70%. And what we see here is that over a period of 35 years, the prevalence decreases by over 90%. The next, if you click, this yellow line then shows the reductions if we were to assume instead a 1-dose vaccination with a lower efficacy, so 80% efficacy over the lifetime, and with the same level of 70% population coverage. Here we see that the reductions in HPV-16 prevalence are not as great as those with the 2-dose vaccination, but there's still quite a reduction compared to no vaccination. So the gap here between the green and yellow lines is essentially what happens when vaccine efficacy is assumed to be lowered from 100% to 80%, but with protection continuing over the lifetime. Click again, please. Here in the orange line, we have a scenario in which 1-dose vaccination with, again, the lower 80% efficacy is associated with higher coverage at 90%. So if we are able to achieve higher coverage with a single dose, what would be the impact? And here we can see that that increase in coverage can actually overcome most of the decrease in efficacy. Next slide. So this slide shows the same reduction, same scenarios of 2-dose vaccination with 100% lifelong protection. But if we click here, we're going to show now 1-dose vaccination with 80% efficacy that lasts for 15 years, fully 80% efficacious for 15 years, and then begins to wane over time, over a 20-year period. And you see that the gap widens between the two scenarios compared to what we saw in the previous graph. And then if you click again, and in this case, the increase in vaccine coverage to 90% does not fully overcome the effects of lower efficacy with a single dose. Although I think we can all agree that, just looking at all three of these lines, the reduction of HPV-16 prevalence in these vaccination scenarios are far superior to no vaccination. So just to summarize some other key findings, we found from analyses in several different countries that compared to no vaccination, a single dose of HPV vaccine yields substantial health benefits. And we don't show you results from our cost effectiveness analyses, but we have found that it is good value for money. It is cost effective, even if the efficacy is lower and duration of protection is not lifelong. And we found that the impact and cost effectiveness of adding a second dose. So if you were to start with a cost effective 1-dose vaccination program, the cost effectiveness of then adding a second dose are really driven by the kind of properties of a single dose vaccine protection, the duration, as we just saw, and possibly the ability to get higher coverage with single dose versus multiple doses. And then just wanted to call out that in one study, we found that single dose 9-valent HPV vaccination in a high HIV prevalence setting was shown to yield high reductions in cancer incidence and mortality. So the potential for single dose in settings with high HIV prevalence is also very promising and is looking to be cost effective. So with just those very quick summaries of modeling results, I'll hand the microphone back over to you, Anne.
Thank you very much. I think we need to add that. Yes, thank you. So I hope that with the brief overview that we provided in this presentation, we have shown that the accumulated data so far shows that single-dose vaccination has a prospect to reduce substantially HPV attributed cervical cancer, associated cervical cancer, and that especially if the intervention is directed to girls prior to sexual debut. Next slide. So there is more evidence that will be forthcoming. There are several clinical studies on the way to address the durability of protection, the efficacy, the effectiveness, and the immunogenicity of single dose. And I will show you a table summarizing the clinical trials that are ongoing. In the next slide. Obviously, not yet, sorry. The consortium will continue to look at newly published studies in terms of efficacy and immunogenicity of single dose effectiveness from population-based HPV vaccination and assess the quality of that evidence. There will also be some future modeling work that will focus on integrating data from the clinical trial as well as from the published literature and assess effectiveness, put the effectiveness data in the existing model as to look also at the impact on low and middle income countries, also with different sexual behavior and epidemiological profiles. And then also in countries where there is a high prevalence of HIV infection, it will be also critical to generate some more evidence on the health and economic impacts of reduced HPV vaccination in that population. So next slide. And this is a busy slide, but this depicts a list of trials currently ongoing that will provide additional data on single-dose HPV vaccination. I'm not going to go into all the details, but the main messages are first, you see on the right, all the stars. These are the timing for results availability. There will be quite a few data that we read in this year, in 2021. But obviously, when looking at duration of the vaccine efficacy for single-dose vaccination, long-term data will also be needed. And this is depicted with some of the data going up to 2024, 2025. So as you see, quite a few studies ongoing. In green, there are 5 randomized control trials. 2 of them are efficacy trial, the Kenshi in Kenya and the Escudo trial in Costa Rica. And there are 3 ongoing immunogenicity randomized control trial in Tanzania, 1 in Tanzania, 1 in the Gambia, and 1 in Costa Rica. Then we have in gray 2 of the trial that you have already heard mentioned before. So the India IARC trial, which is really a trial that look at vaccine efficacy and immunogenicity over time. And that trial has a very large proportion of girls that receive only a single dose, 5,000 girls. And so we will have data this year up to 10 years post-vaccination on clinical outcomes, so HPV infection as well as immunogenicity. But the study will continue to follow that population up to 15 years post-vaccination. The Costa Rica trial in 2020 published data on 11 years vaccine efficacy on prevalent HPV 16 and 18 infection. And that trial is still ongoing to look at immunogenicity up to 16 years post-vaccination, and that include a smaller population of single-dose vaccine recipients. And then there are 2 2 impact studies, 1 in Thailand and 1 in South Africa, that will also bring some effectiveness data of single-dose HPV vaccination. So next slide is a list of resources that are available that compile some of the evidence that we talked about today on single-dose HPV vaccination. And with that, I will turn over to Heather for the Q&A session.
Great. Thank you, everyone, for an excellent presentation. Really fascinating data that you've shared with us today. So many thanks. We do have a few questions that have come in. So let me just start with those. I'm going to actually start with with one that's come in from Selena Shakin, who writes, "Thank you for an excellent presentation. Dr. Kim alluded to this question. Do you know yet whether the effectiveness of the single dose is impacted by choice of vaccine? That is, do we know if 9-valent vaccine is significantly more effective over time than bivalent?" And I will leave it to you all to decide who's best placed to answer that question.
So this is Anna. Maybe I'm going to start on that question. So the 9-valent vaccine having been introduced somewhat later, and because it takes some time to actually gather some evidence on effectiveness, especially if you look at really the prevention of cervical lesion that take a little while to develop. So they are a little bit less data, but nevertheless, there is no reason to believe that there would be a substantial difference. The non-valent vaccine cover some more high-risk HPV types. Nevertheless, I mean, HPV 16 and 18 are still making the majority of the cervical cancer causing types. And I'm stopping here and see if somebody else would like to add.
And thanks, it's Gina. No, I think I agree with what you've said. And I think it's an important question. I think the opportunity, of course, with the 9-valent is, of course, that additional sort of 20% protection you would get. So I think that's partially why, you know, so much of our interest and focus is around the 9-valent. But I think you ask, you know, we know that the sort of the qualities of the two vaccines are slightly different. So yes, there may be some slight difference in durability, but I think that we're excited about the opportunities of the 9-valent and the broad coverage.
This is Anne. Maybe I can add that currently I think the 9-valent vaccine is not procured through UNICEF. So that's so it's the bivalent, the Cervarix vaccine, and the quadrivalent vaccine from Merck. But the non-valent vaccine is not yet, and we hope that maybe that will change over time, but it's not yet procured through UNICEF for Gavi eligible countries.
Okay, great. Thank you for those responses. I'm gonna now turn it over and ask you, Dr. Kim, a question that's come through, and these are related to slides 24 and 25 of the presentation. What are the current coverage rates for countries that have HPV vaccine programs, and is 70% coverage feasible? And I'll leave that to you to respond. I don't know if we need to see those slides.
No, I think it was just based on the assumptions that we made in the modeling. My understanding from our WHO colleagues is that, you know, once a country decides to implement HPV vaccination, the coverage has been quite high and successful. You know, I think there's been obviously disruptions through COVID, and you know, and I think what drives a lot of the question around single dose is, can we, despite the success in many countries that have adopted HPV vaccination with the current 2-dose schedule, would a single dose regimen actually encourage adoption in other countries that are saying, you know, we really can't achieve this because it's a 2-dose vaccine in an adolescent population that's typically not, you know, the target for many EPI programs, but that, you know, for the countries that have elected to adopt that, surprisingly, that uptake has been remarkably high. So we've been asked, you know, I think Heather alluded to the fact that my group has been part of the work evaluating cervical cancer elimination that was in partnership with, you know, WHO. And we were asked to actually look at the, you know, more ambitious coverage levels of 90% with the anticipation that, we could get there, but really at a base case of 70%.
Sure. And I know, Evan, you wanted to also jump in. Please do.
Yeah, sorry. Just to follow up on Jane's comment. While countries that have introduced HPV have seen the first dose coverage in the 70 to 80% range, where things really get problematic is the second dose. So we see dramatic fall off in getting the second dose to adolescent girls. So that's, again, another strong argument for the single dose.
And maybe this is, and maybe there is also an important point is that, currently 70% of the target population, which is girls 9 to 14 years old, live in a country where there is no HPV vaccination program. And I think that that's a striking number.
Mm-hmm.
Sure. Okay. Thank you for that. I'm going to now, this question is for you and or Jane or anyone who'd like to comment. This is from Dr. Sudeep Shrestha. Would you expect differences in outcomes if you separate one dose group, 2 or 3 dose, 2 by vaccine type? That's the first part of his question. The second is, are there data for other HPV related cancer outcomes if single dose protects precancer and cancer other than cervical cancer? We'd love to hear your thoughts on that.
I'm happy to take the number 2 question around the other HPV related cancers. We're increasingly getting better data. There are countries that have cancer registries that are able to help us kind of inform the burden of the other HPV related cancers as well as genital warts in those countries. But there are many more countries out there where the data are not of high quality. And but I know that there are lots of efforts and lots of calls for action for increasing surveillance so that we can monitor this, because obviously, if you think about any of our evaluations for HPV vaccination just against cervical outcomes, we are underestimating to the extent that single dose or any dose can be effective against these other cancers. And we know from trials of 2 dose, 3 dose that they are effective against precancers for the other cancers, other non-cervical cancers. But I think the data on 1 dose, single dose against these other non-cervical cancer outcomes are still forthcoming.
Thank you. So this is, and maybe I can take the first part of the question. So actually, I show you some data that were from the Costa Rica vaccine trial, which is a trial that assessed the bivalent vaccine. But I also mentioned that the India IARC trial that looked at the quadrivalent vaccine is ongoing, and both vaccines have shown that first, they are able to elicit an immune response that is really sustained over many years, and it's really a plateau that remains constant, and that can, even if that plateau is somewhat lower after a single dose, is still maintained over time, and it's higher than after natural infection. And also in the terms of prevention of HPV 16/18 infection, the data shows for both vaccines that that remains also, the vaccine remain efficacious over time. And so I show you also some of the effectiveness data, and that was after vaccination with the quadrivalent vaccine. So even so, there might be some subtle difference between the different types of vaccine. They are all based on VLP vaccine, and they are highly immunogenic, and with the mechanism of protection that we know is conferred through the immune response to the induction of neutralizing antibody. We do not expect major difference to be seen between the vaccines.
Okay, great. Thank you for those. I'm going to see if we can squeeze in just 2 more questions. The first comes from Jillian Lever, who says, do you anticipate that all of the different types of the HPV vaccines, that is Gardasil, Cervarix, et cetera, would be adapted to be effective for a single dose schedule, or would one brand of the vaccine be available specifically for a single dose schedule? And I don't know if that's a question of this group or if that's the question of industry colleagues, but if any of you have thoughts or comments on that, please do jump in.
So this is, and I think we just alluded to the difference in, so for HPV vaccines, for currently the evidence is present for single dose HPV vaccination needs still to be, strengthened with upcoming data, but is there for the bivalent as well as the quadrivalent vaccine. Now there is, the vaccine that has been newly approved in China, Secolin, that is not yet pre-qualified, but under review by the WHO for pre-qualification. There, I think the vaccine efficacy data are very similar to what has been seen with the other vaccines that are available, but there are no long-term data yet from that vaccine. So for a single dose, it seems currently that any VLP-based vaccine might be an appropriate intervention if supported by some of the upcoming data as well.
Sure, and maybe on that note, Anna, I would love to ask one final question, which is, in terms of this group's work going forward, when do you all see any future possibility of WHO and the SAGE committee evaluating moving to a single dose schedule, provided that the data continue to build in a positive direction? Would love your thoughts on that.
Evan, do you want to take that one?
Yeah, I was going to call on Evan too.
Sure, no problem. Yeah, so WHO is will be discussing the current state of the evidence with the SAGE HPV working group over the coming months to get a sense of whether or not the accumulating evidence in some of the trial data that's coming out this year is going to be sufficient to answer the questions and to meet the criteria that SAGE will have for making a policy decision. So we are, it would be wonderful if in a year from now, in the April 2022 SAGE meeting, if they were to have that single dose HPV on their agenda. There's no guarantees. I think we still need to pull this evidence together and still needs to continue to see the positive trend. So I think over the course of the next 4 or 5 months, WHO will make a more concrete plan for their efforts to assess the evidence and make a policy recommendation, perhaps in April of 2022. But with all the COVID activities and all the other things that are going on, it's a crowded agenda, I should say. So we'll just have to wait and see.
Sure, that's understood. And but thank you for sort of setting that timetable and what that might look like in terms of the future. We've come to the top of the hour, so I just want to again thank all of our colleagues for joining today and for presenting these data, which are indeed quite promising and really speak to what we hope is the future of HPV vaccination. And if you all have questions, you're welcome to follow up with me directly here at Together, and I'll try to coordinate and reach connect you with the right folks. So thank you again, and we'll see you for our next webinar presentation. Thanks, everyone. Have a great day.
Thank you.
Thank you.